Welcome to Navigating Insurance and Benefit Options. My name is Fiona Cinquegrana, and I am a social worker on the support team here at Ovarian Cancer Research Alliance. Today, I'm joined with Sarah.
Hi, my name is Sarah Handsman, and I'm an oncology social worker at OCRA.
Navigating these systems can be overwhelming, particularly after receiving a gynecologic cancer diagnosis. In this presentation, we hope to clarify the basics, offer valuable tips to aid with decision-making, and help you understand steps you can take to ensure you get the most out of your coverage and benefits. We'll begin by going over some basic terminology you may hear as we discuss insurance. A copayment is a set fee you pay at the time of service. For example, this is the cost you may be responsible for when you're at a doctor's appointment. A deductible is the set amount you pay out of pocket each year before the insurance company begins covering a portion of your cost of care. Coinsurance, or cost share, is the percentage of the cost of your care that you are responsible to pay after your deductible has been met. And premiums are the monthly fee that you must pay to retain your health insurance coverage. Private health insurance. So there are two primary methods to obtain private coverage or commercial insurance. You may obtain health insurance through your place of work, known as an employer-sponsored plan, or you can purchase a plan through the health insurance marketplace. This is a platform created by the Affordable Care Act that allows users to self-purchase private plans. Each state has its own dedicated health insurance marketplace system, but regardless of state or plan purchase, all HIM plans offer protection for pre-existing conditions, including a cancer diagnosis. There are two primary categories of private plans: fee-for-service and managed care plans.
So fee-for-service plans. These are essentially what they sound like. The insurance company pays the provider a fee for each individual service provided. And they're viewed as the least restrictive of plans in that there are no networks, so you don't have to worry about whether a provider is in-network or out because it won't impact your financial responsibility. They do, however, almost always carry an annual deductible and coinsurance requirements. So there are two main payment scenarios that you'll find in fee-for-service plans. For some plans, the provider bills the insurance first and then bills you for the remaining balance, which is your coinsurance. And the amount you'll be billed will depend on whether or not you've met your deductible yet. In other fee-for-service plans, the provider bills you for the full cost up front. And once you've paid, you'll need to fill out claim forms and submit them to your insurance with your proof of payment. And they may also request your medical records for review. And similarly, whether or not you'll be reimbursed depends on if you've met your deductible yet. So to briefly summarize fee-for-service plans, let's just run through the main pros and cons. So for pros, as we've learned, these are usually the most flexible since there are no networks and you have the freedom to choose and change your doctors at your discretion. You are free to see a specialist without a primary care referral. And another unique aspect here is that there may be some more leeway to negotiate a provider's fees. And the reason for that is since the fees in this case are set by the provider directly, meaning they're not dictated by insurance, some providers may be amenable to a discounted fee on a case-by-case basis. As for some cons, these plans are more expensive because they typically have higher deductibles and coinsurance than their alternatives. And the fee-for-service payment model has also been critiqued for potentially incentivizing quantity of care instead of quality of care. And this can lead to the possibility of over-treatment, meaning unnecessary tests could also be the potential for under-treatment, meaning that some routine preventive services can be overlooked because they don't carry an associated fee. These plans can also require more time and paperwork on your part due to the claim filing process, and it can take up to 90 days for you to get reimbursed. So these are just some key points to keep in mind when selecting a plan.
The second category of private insurance are managed care plans. With this type of coverage, healthcare providers contract with insurance companies to become part of their provider network. To become in-network, healthcare providers must agree to a plan's allowable amount. Allowable amount refers to the maximum the plan will pay the healthcare provider for a covered service. There are three primary categories within managed care plans: health maintenance organizations, preferred provider organizations, and point-of-service plans. Health maintenance organizations only pay for care you receive from in-network healthcare providers. This type of plan usually requires you to select a primary care physician from within their network at the time of enrollment. Thus, the majority of your care will be coordinated by your PCP. This means that you are having a medical issue, you will typically need to see your PCP first, who will then refer you to an in-network specialist when necessary. Some pros and cons. Some pros if you choose to enroll in an HMO plan are that when you stay in network for care, most expenses are going to be covered. These plans also offer lower copays and premiums and have no co-insurance or deductibles. This allows you to more easily control and predict your financial responsibilities. And you only need to manage a single point of contact for care, being your PCP, on account of the referral process. Some cons to enrollment in an HMO plan are less flexibility in terms of choice of care provider, no out-of-network coverage, and occasionally longer wait times to see specialists on account of the required referral.
So, PPO plans. These include coverage for both in and out-of-network providers, although staying in network will always be less costly. They tend to have the largest provider networks, giving you the highest level of choice when selecting a provider. And unlike HMO plans, you aren't required to establish care with PCP, nor are referrals required for specialist care. So just to quickly sum up some of those pros and cons for PPOs, they have much larger networks, which means a wider pool to choose from. You're not restricted to in-network only. And bypassing the need for a PCP referral allows you to see a specialist more efficiently. On the other hand, these are generally the most expensive of the managed care plans because they have higher monthly premiums and almost always carry an annual deductible. And one other potential disadvantage is that choosing your own doctors often means you are the main person coordinating your own care, possibly helping to facilitate communication between doctors, etc., which might be fine for some, but others might prefer to have their PCP as a single point of contact. And lastly, just to touch upon the point of service or POS plans. These include features of both HMO and PPO plans, although they are far less common than either HMO and PPO. So like HMO, you are required to select a PCP upon enrollment, and a referral is required before you can see a specialist. Like an HMO, you'll typically have out-of-network coverage, but only if your PCP refers you to an out-of-network provider.
Next, we'll discuss managing appeals. Appeals can be a very confusing part of insurance navigation, but are often necessary. If your insurance denies a request for a test, scan, or treatment, it's important to remember that you have the legal right to appeal that decision. According to the Kaiser Family Foundation, those who use health services more frequently are also more likely to receive claim denials. Likewise, roughly 85% of those who receive a denial never file a formal appeal, despite the fact that 60% of appeals are ultimately approved in the end. Thus, it's often worth it to go through the trouble of making a formal appeal. The first step upon receiving an initial denial from your insurance provider is to file an internal appeal with the insurance company directly. However, it may also be helpful to communicate with your medical team following a denial. Sometimes, if a healthcare provider updates an individual's medical records to accurately reflect the medical necessity of treatment, the insurance company may be willing to reprocess the request without a formal appeal. That being said, the internal appeal process differs from company to company, but there are generally 3 types of appeals you can submit based on the timing of the denial in relation to the service. Firstly, pre-authorization appeals. This occurs when a request for upcoming or prescribed treatment or service is denied, preventing you from receiving the care. The submission deadline for this type of appeal is within 180 days of initial denial, and the determination timeline is within 30 days of filing. The second type is post-treatment appeals. This occurs when a request is denied after treatment or services have been rendered, leaving you with the full financial responsibility of the service. The deadline for this appeal also occurs within 180 days of initial denial, but the determination occurs within 60 days of filing. Finally, expedited appeals are reserved for urgent situations in which a denial may put one's life in jeopardy or cause intolerable pain. Similarly, the deadline occurs within 180 days of initial denial, but the determination timeline comes within 72 hours of filing. External appeals. If you file an internal appeal and it is denied, you may submit an appeal to your state for review. The state's internal insurance agency or the Federal Department of Health and Human Services then becomes responsible for reviewing your appeal. The submission deadline for an external appeal is within 4 months of internal appeal denial, and the determination comes within 45 days of filing.
So now we are going to review the public health insurance side. When it comes to public insurance, there are two main categories. Medicaid, which is primarily based on one's income, and possibly resources and other categories of eligibility, depending on the state. And Medicare, which is based on one's age or disability status. So Medicaid is a federal program, but it's administered at the state level. This means that while all states are required to offer a Medicaid program that follows specific rules and provides a minimum level of benefits, states can expand upon the federal program, such as by broadening the eligibility criteria to allow greater access to coverage. This also means that Medicaid programs are funded jointly by federal and state governments. At the federal level, one's modified adjusted gross income must fall at or below 133% of the federal poverty limit. For reference, in 2024, this means up to about $15,000 per year for individuals, about $20,000 for families of 2, and about $31,000 for families of 4. But certain states have chosen to expand this income limit for its citizens. So when it comes to a Medicaid denial, you have the right to appeal this decision through an administrative process called a fair hearing, which is somewhat different from the appeals process for private insurance that was discussed earlier. A fair hearing entails meeting with a Medicaid hearing officer, whether by phone, video conference, or in person, to present your request to challenge their decision, providing reasoning to back up your request. The officer must be someone who is impartial to the case, meaning they weren't involved in making the original decision. And for cases in which someone's life or health are in jeopardy, there is an option to request an expedited hearing so that you don't have to wait up to 90 days to receive a determination.
All right, next we will discuss Medicare. There are several ways an individual can become eligible for Medicare. All individuals over the age of 65 qualify, and all individuals with a diagnosis of end-stage renal disease or ALS qualify. The only other qualification option occurs when an individual has been enrolled in Social Security disability insurance for 2 full years or 24 months. There are 4 primary parts to Medicare. Part A is hospital insurance. This covers inpatient care, care at a skilled nursing facility, home health care, or hospice. Part B is medical insurance. This covers outpatient care, ambulatory care, durable medical equipment such as wheelchairs or hospital beds, and mental health services. Part C is Medicare Advantage. This refers to Medicare-approved private insurance plans. And Part D is prescription drug coverage. So there are a few different requirements and timelines in terms of Medicare enrollment. If you are enrolling based on age, you may do so up to 3 months before or after you turn 65. If you're enrolling based on disability, enrollment is automatic after 24 months on Social Security disability insurance. Open enrollment for anyone Medicare eligible takes place yearly between October 15th and December 7th. This includes joining a Medicare Advantage plan, Part C, or prescription drug plan, changing to a different Part C or Part D plan, or disenrolling from a Part C or Part D plan and returning to original Medicare. Medicare Advantage open enrollment applies only to those with existing Medicare Advantage plans and occurs between January 1st and March 31st. And special enrollment allows you to make changes to your Part C or Part D plan outside of these defined enrollment periods due to certain life events, for example, moving or losing Medicaid coverage.
So, Medicare Advantage plans. These plans make up the Part C under Medicare, serving as an alternative to Parts A and B, otherwise known as Original Medicare. And they encompass the benefits that you get from Parts A, B, and usually D for prescription benefits. Private insurance companies contract with Medicare to offer these alternative plans as a means of providing more affordable healthcare to consumers. Like some of the private options we discussed earlier, you'll find that Medicare Advantage plans can function as either an HMO or a PPO, which means that your financial responsibility can vary quite a bit depending on which type of plan you choose. Now, Medigap plans are a different type of secondary insurance because while the Advantage plans serve as an alternative to Original Medicare, the Medigap plans are intended to supplement Original Medicare, meaning that it's intended to fill gaps that Original Medicare doesn't, hence the name Medigap. This also means that you must be enrolled in Original Medicare in order to purchase a Medigap plan. Since Original Medicare only covers 80% of expenses, the purpose of Medigap is to help pay for that remaining 20%. But with that said, these plans don't cover everything that Original Medicare doesn't, namely prescription drugs. So for this reason, you will also need to purchase a separate Part D prescription plan. Most states offer 10 standardized options for Medigap plans, which are named by letters A through D, F, G, and K through N. And each of these plans must offer the same basic benefits, regardless of state or insurance company. Although there are 3 states that are exceptions to this rule, which are Massachusetts, Minnesota, and Wisconsin. But in other words, this means that, for example, a person with a Cigna Medigap Plan G in New Jersey will have the same basic benefits as someone with an Aetna Medigap Plan G in New Mexico. And this doesn't necessarily mean the plans would cost the same, but it does mean that they would be consistent in terms of the basic benefits provided. And unlike Medicare Advantage plans, which have an annual open enrollment period, Medigap plans have a one-time opportunity to enroll. And that starts the first month that you enroll in Part B and lasts for the 6-month period thereafter, as long as you're 65 plus. And lastly, one very important note to highlight is that you may choose to enroll in either a Medigap plan or a Medicare Advantage plan. You cannot be covered by both plans simultaneously.
So here we have broken down Medicare costs by part. So we'll begin with Part A. Premiums for Part A are dependent on the number of years that you have paid Medicare taxes. So if you've paid Medicare taxes for 10 years, your premium will be $0 per month. Whereas if you have paid less than 10 years of taxes, your premium may either be $278 or $505 per month, depending on the number of years you have paid Medicare taxes. Your deductible for Part A will be $1,632 per benefit period. Medicare Part A deductibles do not occur yearly as deductibles typically described in private insurance. A benefit period, as described, starts when an individual is admitted to a hospital and ends 60 days after initial admission if you have gone without inpatient hospital care. After this deductible is met, you then become responsible for a copay that is dependent on the number of days spent in inpatient hospital care. The full breakdown of this is shown in the top right corner of the table, beginning at $0 for the first 60 days and eventually amounting to the full cost of care after 151 or more days. For Part B, your premium per month will be $174 and your deductible is $240. Following meeting your deductible, you will be responsible for 20% of the total fee, also known as your cost share. Part D, premiums, deductibles, and copayments all vary depending on the plan and drug prescribed. However, for both Parts B and D, you may incur a monthly penalty, a late fee, for failing to enroll upon eligibility. Medicare Advantage plans, Part C, costs vary depending on the plan you choose. Although Part C expenses are paid out of pocket, all costs are Medicare approved. Medigap costs also vary by plan, but serve the purpose of lowering the costs of Parts A and B, as previously described. In both Medicare Advantage plans and Medigap plans, you must pay Medicare Part D in order to maintain your coverage. Medicare and cancer. So, coverage and associated expenses for chemotherapy may vary based on where you are receiving treatment. Part A covers chemotherapy administered in an inpatient hospital setting, while Part B covers chemotherapy administered in outpatient settings, such as a hospital clinic or doctor's office. If you are receiving treatment in a hospital clinic, you will be responsible for a standard copay, whereas if you receive treatment at a doctor's office, you are responsible for 20% of the Medicare-approved amount after your deductible has been met. Other factors that may impact cost include whether your healthcare provider contracts with Medicare or any other co-insurance plans that you may have.
So, Medicare appeals. Now, between all the different plan options you have when enrolling into Medicare, there can be quite a bit of variation in how the appeals process is handled. However, there are generally 5 levels of appeals that are consistent across plans, which are listed out here on the slide. And each time you disagree with the decision made at any level, you can proceed to the next level up until you've exhausted all 5. And while we don't have the time to delve into all the finer details of each level for this presentation, the most important takeaway to emphasize is just that you do have the right to appeal a Medicare denial, not just once or twice, but up to 5 times. And while this process can be a bit complicated, you don't have to figure it out alone, because every state has its own state health insurance program, or SHIP. And by contacting your SHIP, you can access free personalized guidance and insurance counseling, including help with the appeals process. Additionally, if you have a trusted family member or friend who's able to help you with the process, you can appoint them as a representative so that they can speak and take action on your behalf.
Next, we'll discuss public benefits. First, we'll dive a bit into Social Security disability insurance. Individuals who have been diagnosed with gynecologic cancer of any stage may be eligible for SSDI. In order to qualify, you must have a medical condition that meets the Social Security Administration's definition of disability. This means that your condition has lasted or will likely last for a year or more. You can no longer perform the work you did previously as a result of your condition, and you are unable to work at the Substantial Gainful Activity or SGA level. Per the Social Security Administration's guidelines in 2024, working at the SGA level is defined by making at least $1,550 monthly. Also considered in your qualifications for SSDI are your work history and whether or not you paid Social Security taxes, as well as accumulating a minimum of 40 work credits, 20 of which must have been earned in the last 10 years. Per the Social Security Administration 2024 guidelines, workers receive 1 credit for each $1,730 earned, amounting to a maximum of 4 credits per year. Some other important information to note is that the waiting period from disability onset is around 5 months. If you are approved, you are then entitled to a back payment from the time of the application to the time of approval. You may also qualify for up to 12 months of back payment or retroactive benefits from the time of diagnosis to the time of application if you were unaware of your SSDI eligibility until after disability's onset. Due to the potential for retroactive benefits, it can be beneficial to appeal an SSDI denial, even if you have already returned to work. Once you are approved, the Social Security Administration continuously reviews your condition to verify that you are unable to work. After 2 years on SSDI, you will automatically become enrolled in Medicare, as previously mentioned, and upon reaching age 67, your SSDI benefits transition to Social Security retirement benefits.
Okay, so the Compassionate Allowance Program through the Social Security Administration. The purpose of this initiative is to expedite the disability applications of those with certain medical conditions that, by definition, inherently meet Social Security's disability criteria by default. This also applies to SSI applications, which we'll discuss on the next slide. And the primary goal behind this program is to help mitigate the financial burden that often accompanies certain serious chronic conditions by providing benefits to the applicant much more quickly. And the SSA maintains a lengthy list of conditions that qualify for this program, including several that are associated with gynecologic cancer, like metastatic ovarian cancer, primary peritoneal cancer, leiomyosarcoma, and others. Another public benefit is supplemental security income, or SSI, which is not to be confused with either SSDI or Social Security retirement income. While both SSI and SSDI provide benefits to those with disabilities, the primary distinction is that the benefits that you'd get from SSDI would be based on your work history, whereas SSI would be based on your income level, irrespective of past employment, meaning that you don't have to have paid Social Security taxes for a certain amount of time to qualify. Instead, you must meet all of the following eligibility criteria, being low or no income, which in 2024 means up to $1,971 a month for individuals. Little or no resources, including things like bank accounts, stocks, vehicles, and so on. And in 2024, this means up to $2,000 worth of resources for individuals. And lastly, you have to have an SSA-defined disability. And just to wrap things up, let's briefly touch upon the Social Security survivor benefits. So when a Social Security qualifying individual passes, their spouse, children, or dependent parents may be eligible for survivor benefits in the form of monthly payments. And this amount would be dependent on the deceased person's work history and Social Security tax payments. And survivors may also be eligible for a one-time lump sum death payment of $255, and that amount is consistent across all cases, regardless of work history and tax payments. So, because the topics we've discussed today can be really complex and nuanced, we could only fit so much detail into one presentation. So, if you'd like to learn more about any of the topics we've discussed here today, here are some helpful, trusted resources with reliable, fact-based information. And these are just a few of the many valuable resources out there. So for a full list of resources, please visit our website, OCRA-HOPE, that's HOPE.org. And thank you so much for tuning into our presentation today. And please know that OCRA's patient support team is here for you if you'd like to reach out to us with any questions. Thank you.
Thank you.